retinopathy وابتدت يمكن تاخد laser treatment. دي الايمج بتاعتها. الايمج ان الشخص الكالر عنده بقت فيدد، فمش قادر يشوف اللون الاشخاص اللي قدامه مظبوط. يمكن عنده ليزر وحصل بيرن في الريتنا وكونسيكونتلي part of the image هو مش شايفها، مش قادر يشوف الصورة اللي قدامه واضحة مظبوطة فيها areas that are black، أو ممكن يحصل straight lines تبقى distorted، فبدل ما شايف الصورة مظبوطة شايفها خطوط بالمنظر ده. احنا عارفين ان diabetic retinopathy كان زمان ايام انا كنت طالب كانت التراكوما. Trachoma was the highest cause of blindness globally. دلوقتي diabetic retinopathy is the highest cause of blindness على مستوى العالم، وبالتالي it's all about early detection. Early detection is really the key for what we want to do and what we want to help people with.
يعني بقى بعد اذن حضراتكم بس لو سمحتوا الصوت عشان خاطر بس نبقى مركزين مع دكتور محمد. بعد اذنكم محدش يتكلم خالص.
So the impact of ophthalmic complications, and actually the word has changed from retinopathy to ophthalmic complications in recognition that the problem of diabetes on the eye goes beyond the retina. ممكن يكون لها تأثير على اللينس، ممكن يكون لها تأثير على الأوبتيك نيرف، it really goes beyond the issue of just the retina. وبالتالي احنا علينا ان احنا نفكر في الديفينيشن rightly ونعمل regular checks، وكمان نفكر واحنا بنعمل اي of these measures نفكر في الايكونوميك ستاتس بتاعت الشخص اللي قدامنا. ف at the end of the day في مصر أنا اشتركت في بحث من اتعمل في اسكندرية من عدة سنوات، من يمكن من 10 سنوات، وكان prevalence of diabetes في about 16 to 18%. Most probably it's even higher now. يعني غالبا 1 out of 6 people or 1 out of 5 people is already a person with diabetes. I'm going to share with you the latest guidelines that we've just done for the Gulf countries. I don't think it matters هي توصيات خليجية ولا توصيات مصرية. More or less you can take of it what you feel is appropriate for your patients, modify it according to the local needs and the local skills and expertise. At the end of the day, microvascular complications, including diabetic retinopathy, are very, very common feature in people with diabetes. The data are patchy. We do not have globally, ولا في الجلف ولا في المنطقة العربية, strong, robust data to tell us the prevalence of the problem, because we don't have diabetes register. لما كنت بشتغل في UK كان عندنا diabetes register. كان كل مريض عنده سكر بيروح مرة في السنة يتعمل له diabetic retinal screen. لكن لما بنكون في سنتر نشيط بتكون الداتا عالية، في سنترز ثانية مش نشيطة تكون الداتا منخفضة. And that's the cause of, you can see here, data from Saudi Arabia, United Arab Emirates, Kuwait, Qatar, Bahrain. It varies massively from as low as 20% to as high as 40%. يعني الدبل. وده بالتأكيد السبب ايه؟ الميثودولوجي. Methodology of the process of screening. هل في process كل مريض بيخش لي العيادة بيتعمل له screening وبسجل الانفورميشن بتاعته ولا لا؟ وحتى لو بيخش لي العيادة أنا، طب ما يمكن المريض اللي بيخش لي العيادة يختلف عن المريض العام اللي بيروح المستشفى. ف different methodologies فيهم مهمة. Of course the person with retinopathy أو diabetic macular edema DME ده الاختصار بتاع diabetic macular edema. Both could be predicted and preventable. لأن المشكلتين دول فيهم correlation. يعني retinopathy نعرف إن في strong correlation مع nephropathy. بس الانترستينج بوينت إن الريتينوباثي دلوقتي بقت a cardiovascular risk. وموست جايد لاينز بتتكلم دلوقتي على إن البيرسون اللي عنده diabetic retinopathy that person is considered as a high vascular risk. لأن لقوا very high correlation ما بين الماكولار إديما والcerebrovascular accidents 2 folds و 2.5 folds with myocardial infarction. وده السبب دلوقتي ان معظم الجايد لاينز بتتكلم البيرسون اللي عنده diabetic retinopathy treat that person as a high vascular risk person and not just simply عندك شوية تغييرات في الشبكية نصلح السكر وهتروح. So if you were to think of retinopathy, its classification is changing. One of the classifications is to classify it as non-proliferative, and then proliferative and maculopathy, and under maculopathy you can have either ischemia or the macular edema. Here I would share with you the recommendations or the consensus of guidelines from some of the Gulf countries. This is the names of so many of the guys, including Riaz Malik, one of our favorites for our conference here, always attending and always supporting our conference. The group is a mix between diabetologists and ophthalmologists, so it's well balanced. One of the aims of the guidelines was to set a standard of care. How should the care be for a person with diabetes with regard to retinal management or ophthalmic management? Of course, what we want, if we were to come with one point, enhanced screening. مش ممكن هنفكر في screening واحنا مش مهتمين بالموضوع. ولو انا بصيت على الاجنده بتاعت مؤتمرات كتير هلاقي الريتينوباثي is very much ignored and many other conditions are well discussed in so many conferences. And obviously the retina and the vision is as important, especially now that we are talking about that the retina is a vascular risk factor. Of course, we want to enhance the recommendation and improve the practice of every single doctor. We know that many children with type 1 diabetes, they never get screened. They get ignored for screening for retina because they are too young. And this is obviously is not correct. In type 1, we say we must screen 5 years after diagnosis in young people. But we diagnose a lot of type 1 diabetes in adults. I shouldn't wait for 5 years because they already have other vascular risk factors which could contribute to the risk of retinopathy. So many patients are high risk and we need to screen them. Pregnancy and retinopathy. The pregnancy process itself means that the pregnant woman needs to have a retinal check at least at the beginning and in the middle, if not every trimester. Of course, the elderly, because the elderly already have a lot of reduced functions, and to have a reduced vision is a very important factor. لو أنا صحيت من عز النوم عندي نيوروباثي مش قادر أحس كويس ومش شايف كويس ويمكن جالي postural hypotension وقعت automatically الناس هتفكر ده stroke ويخش المستشفى ويعمل CT ويعمل MRI and so on. Well, the problem is three simple complications. One of them is preventable by saying to the elderly person, always keep very small light. Always stand up gradually so that you don't end up with postural hypotension. So the guidelines that we've developed aims to eventually make everyone have a standard of care equivalent ما بين أصغر طبيب لأكبر أستاذ. And of course, setting a pathway, understanding when to refer to a diabetologist, when to refer to an ophthalmologist, and of course, setting for the future, identifying the gaps. حاجة من الحاجات المميزة جدا لما نيجي نكتب guidelines بنيجي نراجع السيرفيس بتاعتنا. ايه اللي موجود عندنا؟ ايه البراكتس اللي عندنا؟ واحيانا كتيرة بنلاقي ما عندناش enough data، ما عندناش standardized care. ولما بنعمل highlights على البروسيس ده بتكون نقطة مهمة جدا بالنسبة لنا. طيب as a diabetologist or a doctor with interest in managing diabetes, whether primary care, internal medicine, endocrinologist or whatever, I think the most important point is to remember the need for early diagnosis. خلاص الإيرة بتاعت إن أنا دكتور شاطر وحاطط ثالموسكوب في جيبي وهبص في عين العيان. This is very old type of diagnosis. It's not a bad type, but there is much better ways of screening the eye, better than the simple ophthalmoscope of a doctor who is not a specialist. So screening problems is the inconsistency. جهة عمل شاطرة قوي، مستشفى مثلا let's say أنا بشتغل في مستشفى الطيران، مستشفى الشرطة، عندنا برنامج ممتاز جدا، والمستشفى اللي جنبي أو الجهة التانية اللي جنبي ما عندهاش برنامج. فال-variations in screening process is really quite important, and we need to try as much as possible that this is part of حق المريض. My right is to have my retina screened at least once a year if I have no serious complications. Once I'm diagnosed with some complications, then the frequency will be decided based on what type of pathology I have. Another important problem, we were just discussing earlier about the grading of problems in thyroid. The grading as well of problems with the retina need to be standardized. So the report coming from ophthalmologist A is equivalent to the report coming from ophthalmologist B. The screening process is the same, and we end up with the same level of grading, because that will decide what do I do with the management of my person. And of course, having a standardized approach across the country, across the region, depends on where you're working. So the consensus looked into many available guidelines across the world, the American, the Canadian, and we all have different level of interest. But the bottom line is we need to screen everyone with diabetes. We only say that people with type 1 diabetes who are recently diagnosed and they are young in age, we can wait for 5 years. Otherwise, it needs to be done annually, and the repeat would be according to the diagnosis on what have we found, normal retina or abnormal, and if abnormal, how frequent we should diagnose. الحقيقة البروسيس اوف ريتينا سكرينينج اتغير كتير جدا جدا جدا، والتكنولوجي دلوقتي اللي موجودة بقت ممتازة جدا. I don't even need to refer to an ophthalmologist. المودرن techniques والمودرن therapy زي ما انتم شايفين هنا, this is one of the approved FDA techniques where with a simple camera you apply it to the eye, and the sensitivity and the specificity are extremely high, equivalent to sending the person to an ophthalmologist. So a lot of the artificial intelligence as well as the read, زي ما بنشوف مثلا في مكن الاي سي جي دلوقتي، في مكن اي سي جي موجود اوتوماتيكلي هو بيعمل لي الدايجنوسيس. It reads. I'm not saying we cancel us to do it, but if we have standardized studies that is showing to us that the diagnosis read through the screen of the camera, through the photo, electronically, is highly sensitive and highly specific and approved by something such as FDA, that certainly gives me a lot of confidence, and it is money well spent in any center. So the age of screening is very important, and of course we've addressed the importance about the elderly. The odds ratio for diabetic retinopathy is 7% per year of duration of diabetes. So this is really quite important that we think, and we try to think of whatever scheme we want to do. The relationship between glycemia and retinopathy is extremely high. ولو ترجعتم تسألوا نفسكم ليه 7% is the target HbA1c in type 1? Because 7% was the cutoff figure that you can achieve prevention of retinopathy with minimum hypoglycemia. Going lower, yes, you'll prevent more retinopathy, but on the expense of higher rates of hypoglycemia. فلما نيجي نسأل نفسنا هو ليه حكاية ال7% دي؟ It was from the studies of DCCT related to diagnosis of diabetic retinopathy that was خير الأمور الوسط. 7% يكون I detect under, if I aim for that target, lower rates of retinopathy with lower rates of hypoglycemia. Lower than this, yes, better for complications, but higher for hypoglycemia in type 1. And it obviously got adopted initially for type 2, ودلوقتي كل الكلام in type 2 go as low as feasible because of still the risk of hypoglycemia. Blood pressure, systolic blood pressure in some studies has been shown to be also directly related to the development of retinopathy. Il-UKPDS shown this. One other study, big study, the cord arm of blood pressure did not show this. However, it's very important that we treat hypertension anyhow in general for the health of the individual. So the happy medium of 7% is there. In some cases, you want to go lower to less than 6.5. In some cases, you want to compromise up to 8. But above this, the risk on retinal problems is high. So we've talked about glycemia, we've talked about blood pressure. What about lipids? Are lipids linked with retinopathy or not? And this is a very important point that we need to understand. Glycemic control, I've shown you this before, and you've seen it now. Again, this is the link of the time in years and glycemic control. The longer you end up with longer duration and poorer control, the higher the rates of retinopathy. If you end up with better control and for a long time, sorry. So these two we've already discussed. What about the lifestyle? Of course, healthy lifestyle is essential for blood pressure, for lipids, for glycemic control, and this is part and parcel of any recommendations for complications, whether it's retinal, renal, whatever, neuropathy, anything. I'm going to share with you some of our hospital data, our center data. 1378 مريض عندهم retinopathy, diagnosed as retinopathy, type 1 and type 2 versus people with retinopathy. Unfortunately, people with retinopathy are worse when it comes to control. And maybe that's why هو البيضة ولا الفرخة هو جالهم retinopathy perhaps because of the worse control. When you look into the percentage of achieving LDL of less than 100, 26% only in people with retinopathy. When you look into HbA1c less than 7, 28% versus 51% in people with type 2 diabetes. Obesity was even 47%, equal to those with type 2 diabetes, although of course a high proportion of people with retinopathy are people with type 1. Renal function, only 86% had an EGFR above 60 in people with retinopathy, which means 14% of people with retinopathy have also EGFR below 60, and let alone if we check microalbuminuria. So when I look into the EGFR itself, as you can see that 32% have stage 3A, stage 3B in red was 39%, or let's say 40%, and 29% are 55 or more. If you to look into triglycerides, triglycerides are important when it comes to retinopathy. Only 37% had a triglycerides, fasting triglycerides, less than 100. The rest were higher, and some of them were pretty high. So glycemic control is really important. There is no drug that causes retinopathy. The data that we saw in some of the studies on GLP-1 receptor agonists causing retinopathy, when it was thoroughly dissected, it was shown to be because of the power of the drug and the strong reduction in HbA1c that led to retinopathy. احنا عارفين حاجة من الحاجات اللي ممكن تحصل في الretinopathy, sudden lowering of HbA1c. And because of the GLP-1s, especially the more modern ones being so powerful, in clinical trials, we saw a sudden drop, and in some cases it caused retinopathy. But further analysis and per FDA and others, there is no link between any glycemic drug and causing retinopathy. So the bottom line is, كل الأدوية ممكن نستخدمها عايزين نوصل ل very good glycemic control. Blood pressure management, of course, is very important. Many studies have shown better outcome in people with better control, apart from one trial only. And of course, the drugs that target the renin-angiotensin system are preferred because of the link of retinopathy with microalbuminuria and with nephropathy, so we recommend this as well. Lipid management. It's quite interesting when you look into the studies such as Field and Lens. These were studies done on fibrates in people with early stages of retinopathy or no retinopathy, and with mildly, they were all on statins. And it was shown and proven that fibrates are very useful in people with early stages of diabetic retinopathy. It can stop or halt the progression of diabetic retinopathy. It has no impact on the cardiovascular outcome. It has an impact on progression of diabetic retinopathy. I don't want to bore you with more of what you already heard about the importance of lifestyle, cutting down on carbs, cutting down on fat, cutting down on salt, and of course being vigilant. So what will the ophthalmologist do? You've diagnosed a person with retinopathy, you referred to the ophthalmologist. The ophthalmologists, in very brief, have a very important point in confirming the diagnosis, setting the management plan, and certainly referring to the diabetologist as well, because maybe the patient went directly to the ophthalmologist and there is no link, no communication between دكتور العيون ودكتور، احنا في مصر بنسميه دكتور الرمد، صح؟ واخدينها من زمان، من ايام الرمد ما كان هو المشكله. خلينا نقول دكتور العيون ودكتور السكر لابد يكون في تواصل وتعاون بحيث ان احنا نوصل للخطه الافضل لهذا المريض plus the regular monitoring. Driving. أنا اشتغلت في بريطانيا 24 سنة. مريض السكر رخصة السواقة بتاعته بتجدد كل 3 سنوات مش كل 10 سنوات. ولابد عشان تجدد يكون عدى على طبيب يقول إن قدرته على الرؤية على الإبصار جيدة إن هو تسمح له إن هو يقود سيارة. لأن المشكلة مش هو بس، هو والمجتمع. لو أنا مش قادر أشوف كويس. وطبعا as a diabetologist you would also not just look into the retina, you would look into hypo-awareness as well as neuropathy. I lost the sensation. مش عارف أنا دوست بنزين ولا دايس فرامل ودايس قد إيه. مشكلة كبيرة. Hypoglycemia unawareness أو frequent hypoglycemia. So a person with diabetes when it comes to safe driving need very much. طيب هنقدر نغير قوانين في بلادنا؟ صعبة. لكن نقدر نحط best practice. Best practice in a person with diabetes need to have these criteria. خد بالك انت بتسوق سيارة، خد بالك على نفسك وعلى الناس اللي في المجتمع. ايه الكرايتيريا؟ عندك احساس كويس في رجليك ولا لا؟ بتحس بالهايب ولا لا؟ قادر تشوف ولا لا؟ لو ما عندوش الكلام ده يبقى لازم اقول له ما تسوقش. باختصار ما تسوقش. احنا حاولنا في الحكايه دي الحقيقه، ورحنا في الجهه المنظمه في الامارات ودونا على جهه التراخيص المهنيه وقالوا لنا، او يعني الشخص اللي قابلناه قال لي انا ما عنديش مشكله، انت كده هتجيب لنا مشاكل، احنا عندنا سموث بروسس والحوادث عندنا قليله. فطبعا ده كان خطا، ونتمنى من الجايد لاينز والريكومنديشنز ان الجهات التخصصيه اللي بتدي التراخيص تاخذ بعين الاعتبار في النقطه دي. طيب future directions. Of course, we need standardization for the methods of screening. We need to agree on best management and techniques for people with diabetic retinopathy, specifically when it comes to هنا احنا بنتكلم different countries. يمكن احنا مشكلتنا في مصر الجهات المنح او اللي بتعالج مختلفة جدا من مكان للتاني. فperhaps the power of the society is to set best practice يطبق في الشرطة، في الجيش، في التأمين، في القطاع الخاص، بحيث ان نكون كلنا بنمشي بنفس الاسلوب. Of course, improving access to care. ان انا يكون عندي القدرة ان انا اشوف طبيب ويعالجني بشكل كويس، لان يعني the vision is something extremely important. And of course, some regulations or even best practice with regards to driving and diabetes. Thank you. And if you have time, I'll take questions. If you don't,